Thank you, Dr. Neri. Dr. Neri, can you see my slides and can you hear me well?
Yeah, perfect. Perfect, Dr. Dan.
Hi, Dr. Neri. It's been a long time since I met you. I'm honored to be given the opportunity to share on this topic on the role of UBE in motion preserving spinal surgeries. I'm from Singapore. I'm from the Department of Orthopedic Surgery. Currently, I am in Khoo Teck Puat Hospital. This is where I work now. I'm going to be going to a larger hospital in Woodlands Health in Singapore. As Dr. Tan has pointed out, it's a small island city just south of Malaysia with a beautiful sea view. And today I'll be sharing on various topics under this whole role of motion preserving spinal surgeries by UBE, but I'll first start off with several concepts that we often use in traditional surgery, the benefits of motion preservation in spinal surgeries, and how we can use UBE in these. We know that in conventional spinal surgeries, our topmost priority is patient safety, and they have to come out of the surgery well and safe. And often, spinal surgeries, the aim would be the decompression of neural elements, whether it is because of claudication, because of pain, or neurological deficits, before the other objectives of realignment of the spine because of instability or deformity. Finally, we as surgeons, with all these being considered, we then considered the value, the outcome, the durability, costs, and also risks. Certainly, in most of the conventional surgeries that we've grown up with, we've done training in, the price of decompression often is the tissue damage because of our approach as well as the complications associated with it. Therefore, often when we try to decompress, due to the destruction of the soft tissue of the facets, then fusion becomes a procedure that often comes together with it. But we know that with the advent of multiple minimally invasive techniques, such as the tubular retractors compared to the open techniques, these has got advantages such as lesser operating time, less blood loss dissection, complications, and also better patient mobility. This, therefore, is accentuated with what the speakers earlier has talked about, like Dr. Tan has talked about how endoscopic techniques have got even more advantages. It really brings out the minimally invasive principle, and they're able to dissect the soft tissue less injury to the muscle, better viewing of the neural elements, also, finally, better recovery, lesser hospital stay, and better cosmesis. You can even see that within the scope itself, in a deep ligamentum flavum, capillaries can be seen, and this is not something that we often are able to differentiate under the microscope. So with conventional surgery, from decompression and fusion being often done together, we now, with endoscopic surgery, a phenomenon that most of us endoscopic surgeons find is that we're able to achieve decompression without having to do a fusion procedure, and therefore the amount of fusion procedures after we've done endoscopic surgery has dramatically reduced. And this comes to the second concept of fusion, where we know that from a large database in Medicare in the United States, when a minimally invasive interspinous device is compared against open decompression, fusion, and fusion alone, they found that in terms of long-term complications, just by approach itself, decompression has got 1.3 times the complications. And when we add on fusion to that, then this increases even more to more than 2 times. So therefore, fusion in itself has related problems such as pseudoarthrosis, adjacent level problems, facet arthropathy, and the proximal or adjacent levels being subjected to higher stress, and therefore spondylolisthesis and spondylolysis. And the whole concept of motion preservation is really to replicate what is normal spinal mechanics, and so there would be lesser complications. And generally in literature, we talk about disc replacement, dynamic stabilization, interspinous process devices, and laminoplasty. I'll just quickly go through some literature. We all know that cervical disc replacement does better than disc fusion. This is a 10-year outcome, lesser adverse events with disc replacement. Same for the lumbar spine, where investigational disc replacement group does better than the A-lifts. Dynamic stabilization has got lesser repeat surgeries. And interspinous processes you saw earlier has got lower risks and costs. Laminoplasty in itself, this is the latest meta-analysis that I found. They seem to be comparable to fusion. However, this advantage is just weakly significant. And so overall, the role of UBE in these procedures that we're familiar with, you can see on the left-hand side, UBE being a biportal surgery, we are able to achieve quite a lot of these decompression and without having to do fusion. But even if there is a need for fusion, this can be done. And you will see here in the cervical spine posterior approach, the biportal surgery can be performed for foraminotomy, for decompressive laminectomy. You can do screw fixation, laminoplasty. And for the thoracolumbar posterior approaches, similarly, this can be done with UBE for laminectomy, for the ligamentum flavum ossified ones, foraminal decompression, as well as interbody fusion. And this can be done with UBE. But what we really want to start off with is once again, we want to know and be very familiar with the principles of UBE, and this was popularized and emphasized by Dr. Son, who emphasized on the various 7 principles that he always talks about in the fluid medium management, triangulation, how the lens is inside the body, giving you a very clear view, and that the lens is always moving for us to be able to visualize. So just going on to the applications of UBE and how this can be applied for the different spinal pathology that we as spinal surgeons see. And so the first case, starting from the cervical spine in terms of foraminal stenosis, you can see that one can decide that you may want to do an anterior procedure or a posterior procedure. And we talked about earlier how I would prefer to have done a motion preservation, given that if this patient has got appropriate indications, then but you can see with the UBE, one is able to achieve very good decompression just by a foraminotomy. And results also show in some of these meta-analysis that when we do a disc replacement versus a foraminotomy, the complication rates seen in the disc replacements is higher simply because of the approach, where patients experience hoarseness of voice, perhaps swallowing difficulty after such an approach. And the reoperation rates are fairly similar between both groups for the foraminotomy and the disc replacement. In myelopathy cases that we see also commonly, endoscopic posterior decompression is a viable option in which if somebody has got a stenosis, we are able to decompress that. And the outcomes also, according to studies, have been very similar between the endoscopic decompression group as well as the ACDF group. And in this, you will see in this particular paper that the operating time is shorter in the endoscopic group compared to the ACDF group. Intraoperative blood loss is lesser in the endoscopic group, and the hospitalization stay is also shorter. So certainly this is attractive to us as surgeons to be able for our patients to return to the community after a surgery. One of the motion preservation spinal surgeries in the cervical spine is laminoplasty, that we traditionally do it open. And Dr. Zhang Wei, one of the earlier speakers, has published on a case in which he did a laminoplasty under UBE with these portals and using these suture anchors. Going down to the thoracic spine, this is these slides are a courtesy from Dr. Son. Traditionally, we know that we're able to achieve good decompression if we were to go through the posterolateral approach, we have to take down the costovertebral junction and go through this in order to remove that thoracic disc that's causing that compression. With UBE, this can be easily done, and this will achieve very good results. And you will see here, and this is how this can look like without having to perform a fusion if you were to take down the entire facet. But really, this depends on the pathology and whether one is able to adequately achieve this. In thoracic myelopathy, the posterior approach to achieve an anterior decompression is also similar. And the posterior versus a posterior decompression instrumented fusion, you can see how in the posterior decompression fusion compared to the decompression, they're fairly similar, and you will see that the recovery rate seems to be better with just the decompression alone compared if fusion were to be performed. So certainly this points to us that perhaps when we are able to perform UBE well, we can achieve a decompression, and therefore there may not be a need for us to perform fusion in these cases. Lumbar foraminal stenosis is one of those conditions which I find personally that has shifted my practice, in which I'm able to do an endoscopic decompression alone without having to perform fusion, because I do not need to take down a whole facet. And we'll go through some cases that I've performed. Lumbar spinal stenosis, similarly, I'm able to achieve good decompression without having to perform fusion. You will see here that in this meta-analysis, in which there is put results that between decompression alone versus decompression and fusion, you will see that just decompression alone has got lesser blood loss, lesser length of stay, and they have got fairly similar reoperative rates. These comes out just last year in 2023. So with these applications in mind, these are some cases that I've performed. This is a 54-year-old male who has got pain in left neck to his thumb. You will see here on the left-hand side, at the C4-5, there's foraminal stenosis. And C5-6, there is also a foraminal stenosis. I'm able to achieve this with these two levels, with the inclinatory and sliding approach. And so those are the laminotomies that I've performed to access the foramen. These are just two incisions that I've had. This is a post-op CT scan to show how I'm able to achieve that. These are intraoperative II images, radiographic images, to see how the nerve hook can go all the way to the lateral extent. And these are images you will see. This is the cranial side. I came from the right side, did the inclinatory approach to open up the left C4-5 and the left C5-6 foramen. In cervical myelopathy, this is a 40-year-old bus driver who really requires his neck range of motion when he does his occupation of driving the bus. So you will see here on the pathology that it is an anterior-sided sort of a pathology from the disc bulge, both at the C4-5 and the C5-6. And in this case, I opted for a posterior decompression. You can see how the thecal sac now has got CSF behind, and that it is quite well expanded compared to before the surgery, with just two incisions like that. And he was back to work very quickly. In thoracic myelopathy, I have a 77-year-old male who remained unsteady after cervical and lumbar spine surgery. We then evaluated him for an ossified yellow ligament posteriorly, and this is what you will see at the level of T10-11. After the decompression, it is well decompressed, but still there is some signal within the thoracic cord. Lumbar foraminal stenosis. This is a 69-year-old cleaner with severe right gluteal pain to the calf, and she was unable to walk. Central canal looks quite all right, but on the right-hand side, you will see how the lateral recess and the exiting foramen has got significant amount of stenosis. This is an intraoperative CT scan that we did, and you can see how some of that are calcified osteophytes. What is important, and what we've also realized, is on the parasagittal cut, some of the end plate spurs that's being described by Dr. DJ Choi also mention how some of these osteophytes coming out from the end plate causes foraminal stenosis, and sometimes this can be well addressed with the endoscope. And this is something that with the open approach, we will just take down the facet, and with a fusion, then that could be easily solved. But with endoscopy, one needs to be very precise with the offending pathology to be able to achieve a good result in these sort of patients. And this is something that I've also increasingly pay attention to. Intraoperatively, I'm able to put my dissector all the way through the foramen, and this is my instrument. You can see how I went on the right side. Intraoperatively, so these views, this is on the cranial side. This is the IAP of L4, SAP of L5. This is the L4 exiting route that I can see going out through the foramen, and the pedicle lies right here with the disc space here. This is my probe just going out through the foramen and how I would test it. And this is a great view, which I often is not able to see under the microscope in open surgery. This is the thecal sac here. And as you come down here, just going down, you will see the traversing L5 route here. So with the endoscope, one is able to achieve very good decompression, able to visualize the L4 exiting route and the L5 traversing route. Finally, biportal endoscopy, UBE, has also changed my practice in dealing with lumbar spondylolisthesis. You can see this 54 years old real estate agent who needs to walk regularly, is a recreational runner. She has got left-sided radicular pain. You can see how this is a grade 1, almost going to grade 2 spondylolisthesis of L4-5. This reduces well on the MRI, and you can see how the lateral recess are tight. Post-decompression, I'm able to achieve, you can see how the ligamentum flavum has now been removed, and I'm able to get a good clearance, and she was very happy with it without having to perform a fusion surgery, because that would impair her ability, her back mobility, and given that she's also fairly young at 54 years old. So overall, my take-home messages for everybody would be that UBE is a viable alternative to traditional open surgery. We know that UBE can reduce tissue trauma if we were to just go to that target point very specifically to achieve the surgical aim of neural decompression without the need to perform fusion. Motion preservation should be a key consideration now that we are able to separate how decompression and fusion is required with separate indications, and without having to marry the two often if we were to do open surgery where there is a lot more tissue dissection. And certainly this has to be done in suitable patients with spinal pathologies that are indicated. UBE is synergistic with the principle of motion preservation, and this ties in with how we are able to preserve the health of our spinal patients for a longer term. So thank you very much. I've ended my talk. Time back to you, Dr. Neri.